thank you for this presentation. Maybe you exaggerate a little bit. It's a pleasure being here. I remember when we discussed with Alan, he asked me to give the talk at like closing this meeting, and I say, okay. It's okay because you have just to follow the meeting and then make sure that you can wrap up. You have some topic. But now, 2 days ago, he called me and said, yeah, can you do the keynote speaker? I said, what can I say about the keynote speaker? So I did not have any clue because I was following I was co-chairing the CPHA in Durban last week. So I started to put something last night. I think this can be interesting. So let's see. So I believe that as the phage and genomics, data, everything is linked to the public health because everything that we are doing, if there is no public health interest, it means nothing. So this is how I put the title. So those are just a few multiple outbreaks that we had in DRC. As you can see that each outbreak, I don't call it an issue, I call it opportunity because each outbreak helps us to shape what we are now. We learn, we train, we get more expertise, we get more capacity, more equipment, and so every outbreak helps us to shape. And I would like to thank all different colleagues here from IPD, I see Musa here, who really help us since the beginning, 2018, to start the sequencing in DRC. And then after that, in 2022, when the outbreak occurred in Uganda, we went to Uganda to work with our colleagues in Uganda. So I think this is also a way to show how collaboration can be between different countries. So as you can see that we moved from 2018 to 2025 with different expertise, experience, equipment, moving from one outbreak to another, and so on. And this helped us also to grow our team. We started with 3 people, and now we have more than 20 people working in my lab. So all those data that we are gathering have impacts. That can help to understand the transmission. That can help also to understand, for example, if what we are using as diagnostic test can be used for this new variant, new virus that we are seeing. We can also use this data to kind of understand the origin of the pathogen. At the same time, we can also use this data to make some synthetic, I can say, viruses or organisms that can be used to kind of evaluate the vaccine, the therapeutics, instead of using the wild type pathogen. So, talking about Ebola. When there is an Ebola outbreak, there are 2 questions mostly. Is it a spillover or is it an outbreak coming from a persistent source? And before 2018, I know that in 2014, during the outbreak in West Africa, it was the first time that we conducted this trial with the vaccine. But the vaccine was approved and was effective, and I think was effectively used during the outbreak in 2018 in DRC. So before that, all different action, or I can say action toward the outbreak, Ebola outbreak, was concentrated to the 4 pillars. As you can see there, case detection, contact tracing, dignify and secure burial, and isolation of a sick patient. And then from 2018, we have other tools like vaccination and specific treatment. But despite all the progress that we do here, you can see that the case fatality rate of Ebola is still pretty high. And here is a timeline of a different Ebola outbreak that we had in DRC, 16 in total, 15 caused by I can say the Ebola Zaire species, and one caused by the Bundibugyo. So Ebola Zaire is a kind of the more prevalent species in DRC. But so meaning that because we also have Bundibugyo sometime, it's always important, and we have this connection with Uganda where they have Sudan. It's always important to use the genomics to understand what type of species we have, so we can very quickly put in place the public health actions. So the first thing that we did, 2018, we call it rapid, 10 days after declaration, we got the sequencing, and I think Alison can tell me, oh, we did a record. But this was in 2018, And so we were able to get like a fragment of the virus, and very quickly we were able to inform that, oh, this is Ebola Zaire, so we can use very quickly the vaccination. So this helped to contain the virus, the outbreak within, I can say, 2 months almost. And then, during the same period, when I was about to leave the country to go for my PhD, because I needed to finish my PhD in Montpellier. And then the same day, the same night, we received a call from South Kivu sending samples, suspect cases of Ebola. I thought that, okay, it's in North Kivu, it's the first time. There's no like a big forest there. So probably that will be negative, and I can the next day leave the country and go for my PhD. And then I can say, unfortunately, those samples were positive. And the big question was, it's almost the same period. We had Ebola in Bikoro and now Ebola in North Kivu. So are they both linked? Is there someone from Bikoro who travel and then start a new outbreak in North Kivu? So we did with the genomics very quickly. As you can see, we received the sample August 1st, and I can say about 5 days later, we were able to get the sequences and show that it's also Ebola Zaire, but it's a different outbreak. So very quickly, the same tools that we use in Bikoro could be very, very quickly transferred to North Kivu and help to control this outbreak. But we also find out that even in Bikoro, we had some issue with the diagnostic, because in Bikoro, it was the first time that we tried to use the gene expert. And at the beginning, we used mostly kind of conventional, I can call it like a conventional qPCR with different primers. So detecting the NP gene, the GP gene, the L, and the VP35, VP40. So meaning, and sometimes what's happened is that when you use this PCR, sometimes you detect the GP, you don't detect the NP. You detect the VP35, you don't detect the VP40. So it was difficult because people are waiting for the result, and you have the result, you don't know, is it positive or negative? Can I just confirm because I just see the L, or should I wait to see also the NP and others? So it was a pity. So we decided, okay, and it's a difficult in the field to use like a conventional PCR. You need 3 different rooms. You need a room for reagent, and you need to avoid as much as possible the contamination. It's not possible in a field condition. So we decided, why not using gene expert, for example, because it's a closed kind of PCR that can be easy to deploy in the field. So we decided to start to use GeneXpert almost the end of this outbreak in Bikoro. And when we had this outbreak in North Kivu, and we saw that, okay, this variant of Ebola is a bit different from what we see in Bikoro. Could we have the same issue with the diagnostic as we had in Bikoro? So we checked, and we found out that despite like one mismatch that we saw in the GeneXpert, like NP, but this did not affect the detection with GeneXpert. So we decided to use the GeneXpert during this outbreak in North Kivu, and it was spectacular because we were able to deploy 11 labs during this outbreak, and we analyzed around 200,000 samples. And this was also an opportunity because when we got all of those samples, we were able to get funding to have our new biorepository. So seeing that every step, everything that's happened, we try to turn it to a kind of an opportunity instead of an issue. So during this outbreak, we were able to integrate genomic sequencing to help and respond to this outbreak. What happened? Normally during an Ebola outbreak, we have our lab waiting for samples and then running the samples mostly to confirm. And we can do sequencing later on to compare the transmission chain between what the epidemiological team in the field say and what we can see with the genomics. But here, it was a kind of a particular situation because at the east part of DRC, where there is a kind of a long period of conflict, it was difficult for the team to go every time to the field. So it was kind of, sometimes you spend like a month or 3-4 weeks. You cannot go and investigate in some places where you see cases coming up. So the role, this is where we saw the crucial role of the genomics because we were able to kind of see that those isolated cases, and using the genomics, we were able to link them to say, okay, this what we are seeing here can be linked to that one. And it was easy for the epidemiological team, at least, to conduct some work, some actions. So what happened also, because we had many data, we generated many data, we were able to detect what you see in circle, like new outbreaks linked to survivors, 2 in Beni, 1 in 2021, another one in Beni in 2022, and another one in Butembo in 2021. So meaning that if we were not able, can you imagine that we are not able to generate all of those data, and I think those outbreaks, the 3-1, will be probably considered as maybe new outbreak instead of outbreak linked to the previous outbreak. So this was not only in DRC, but this happened also in Guinea, where we see that genomics suggests origin from persistent infected survivor. And we see in Guinea that this happened almost more than 5 years later, and we don't know if this was linked to a survivor. We know that this new outbreak was linked to the previous outbreak, but how? We don't know. And what I would like to highlight here is that this comes from my colleague in Crozier, who always say that we need to have this humility because we see something, but most of the time we don't understand why this happened. And so the next one is this relapse case that we saw in North Kivu, that's a relapse case and then connected to a secondary transmission. So this happened, the case was vaccinated. Why? Because he was a driver, a motor driver of the cases from the village to the treatment center. So then we decided to vaccinate all different people who are playing this role. So he was vaccinated in December, but unfortunately in June, he developed some symptoms of Ebola. He was confirmed, treated, and discharged. And 6 months later, he developed a new episode of Ebola. At that time, it was difficult for him to realize that this is Ebola, because he said, yeah, I had Ebola, I was confirmed, I was treated. So this is maybe something else. So he moved from one village to another, from one traditional healer to another, from one treatment center to another. Until some people from our team met him because we knew him very well, and so they decided to bring him back to the treatment center where we confirmed, but unfortunately he died. So what happened is that from one case, this guy kind of led to a huge transmission of the outbreak to more than 90 people and spread in more than 5 health zones. So we can see that even from a survivor or maybe a relapse case, we can have a huge public health consequence. So could we think about like a new viral reservoir? Could we say that human could be in somehow, like in DRC, where we see many outbreaks coming back again? Could we think about like with some people infected from previous outbreak can be the reservoir of the virus? What do we know about the presence of the virus in survivor? Where? We know that's in the iron, the testes, in the brain, but where else? And who, as I can say, confirmed case, is more susceptible to keep the virus in them, and for how long? So there are many questions which we don't know. And what do we know about the subclinical Ebola virus infection? And so then the new outbreak, the 16th one in Bulape. So this outbreak occurred in Bulape. Bulape is the territory of Mweka. Mweka had 2 previous outbreaks in 2007 and 2008. And then what we saw in Bulape is a kind of situation that should remind us that there is an outbreak, but there is what we call the period between outbreaks where we should act to make sure that we have a kind of basic capacity that can help to respond quickly. And this is one example. So you can see that there is an index case going to the hospital, and we have this nosocomial transmission. So everything started from the community going to the hospital, and the amplification was done at the hospital. As the previous outbreak in Yambuku and other in Kikwit and other outbreaks were described. And then there were, unfortunately, some healthcare workers who died. 9 health zones over the 19 were affected, and you can see the number of cases up to now. So the last case, I think, was confirmed in September 24. So we did even better here. We were able to confirm the case very quickly within 11 hours and 30 minutes. We received the samples at 2:30, and the sequences were available at 3 a.m. The team remained in the lab and they sleep there. But we were not able to release the sequences until the official declaration from our Minister of Health. So what we found out that it was a new spillover, and we link it with the Yambuku outbreak, maybe also because of this low evolution of the virus in the reservoir, which we don't know. So we are trying to understand more about the transmission in human, but what's happened in the reservoir, we don't know exactly. So we were able very quickly to deploy the lab, to deploy the treatment, even the vaccine, but we were not able, despite all of those, I can say, capacity to really reduce drastically the case fatality rate. As you can see, with the treatment, we were able to save more patients, but the case fatality rate is still high. 40% is still high if we have the vaccine, if we have the specific treatment. And we try also with the post-exposure, with giving to 2 babies, but it didn't work. So the vaccination, we vaccinated many people. So using the sequencing, I can say, result, we were able to also deploy the vaccine, the specific treatment very quickly. So then, what I wanted to show here is the delay. So we were able to deploy very quickly. I can say within the 5 days, we have the team on site with the specific treatment, with the vaccine, and so on. But it was late. Because as you can see, when the alert was given, when the first case was given, we could be able to do better. So every time that we delay, and this is all those, I can say within 20 days, we had all 33 deaths among the whole death that we had. So meaning that we could avert some of those deaths if we were able to react very quickly. If we are able to have a kind of a basic capacity in place, good IPC where the team and the team being trained and capacitated. And so what we also observe is that the longer the delay in the hospital admission, the higher the case fatality rate. And also what we observe also that when we start getting trust of the community and the community can come a bit early, then we can see that the curve of the case fatality rate decrease. This decrease, I don't know if it's only due to the fact that we were doing well or to the fact that we were already at the end of the outbreak. So, regarding the drivers of the outbreak, we think that there are many drivers that usually can explain why we are seeing this repetitive outbreak, but what I put in red is the weak health system, which is really important. Without that, we will be surprised, we will be late, and we'll have high case fatality rate, despite all the vaccine, the treatment, the tools that we may have. It took us 4 days to travel from Kinshasa to the field. So it's not possible to have this kind of delay when you have this huge outbreak like Ebola in the field. So going to Mpox. Another paradigm. How we move from no public health threat to kind of a global public health issue? We don't know. We just observe that before almost, I can say, from the discovery of the virus to 2000, I can say 16, we have 2 different clades in Central Africa, in West Africa. The transmission secondary cases were very low, a few. I think the longest generation described was a bit, I think, 4 or 5. And more we see secondary transmission, more and more we see less severity of the disease. And even when the outbreak occurred in the US, the clade 2, because it was the case coming from West Africa, there was no secondary transmission. And we analyzed the samples during our work on Mpox, the sample that we got from 2007, compared with the sequences from 1970. So 30 years almost apart, we didn't see like changes. So the virus remained stable. But what happened? So now, from 1917 to 2016, this virus remained mostly zoonotic with limited secondary transmission, mostly affected the young people. And then this happened. With this outbreak in 2017 in Nigeria, exported in Singapore, Israel, UK, in the US, and then the global outbreak. And we observed this rapid change on the virus. Why? We don't know. And the rapid change was mostly with the ApoB mutation, mostly in the 2B, which created this global outbreak. And we found out that the other clades, 1 and 2A, remains almost silent and mostly located at mostly zoonotic. But in DRC, we had this new outbreak in South Kivu, and mostly affected young adults with sexual transmission. And at the first time when I got this information, I say, oh, the South Kivu is a mining zone. There are many people coming from outside. It's probably the 2B. And then when we analyzed, it was the 1. And a very different clade 1, with a different pattern, very different from what we saw before. And when we checked, we saw that, oh, ApoB mutation most in this clade compared to the other one. So it's easy to be transmitted from human to human. But this changed very quickly because we see that even the clade 1A, which remains silent here, mostly zoonotic, acquire also ApoB mutation and become more and more transmissible from one human to another. And we see this huge transmission in DRC and also in the rest of the world that led to WHO and Africa CDC to declare this kind of a global issue for the second time. And we can see here how the dynamic of cases in a different country, a few countries before, and how many countries were also affected. And so now we are facing this kind of outbreak with 4 clades. We started with 2 only, and now we have 4 clades with 3 that are now able to transmit, to go through transmission from like sexual contact and even spread in a sexual network. And we see also at the same time many independent zoonotic cases. So the epidemiological change, so we are facing now a zoonotic outbreak and a human-to-human outbreak. We have 3 clades that are able to go through the sexual network. We don't know yet the impact of other sexually transmitted infection. And we believe that even the 2A, which is still silent for the moment, mostly zoonotic, can also acquire the capacity to be transmitted easily from human to human. So another thing that I would like to point out is also the role, again, of the genomics. We had a case of skin lesion in pig in a region endemic of Mpox. The team in the field, they had gene experts. They collect samples. I don't know if it was a contamination of what happened, but when they analyzed, they found Mpox. And they send a report to WHO, to everyone, that we found Mpox in the pig. And then we call with the US CDC and they say, no, it's no way. It's not possible to find something else if it's not Mpox. If it's Mpox, if it's a final gene expression, should be Mpox. I said, okay, let's get the samples. And then once we get the sample from the pig and from the human, we found that it was a swanpox, not Mpox. And we didn't see any cross-contamination between human to the pig or the pig to the human. So the human had Mpox and the pigs had swanpox. So it was important to clarify this situation. So in conclusion, we made significant progress on the genomics, data sharing, and so on, but that are still, I can say, limited in a few countries. There are a few questions that we need to ask ourselves to see how we can move from a few countries to a large majority of countries. Sharing the data, making progress in the genomics. How we can build trust, transparency, data sharing. Which mechanism that we should use for data sharing, and which platform. And how those platforms can be interoperable. And also the right of people who are providing, institutions, countries who are providing those data. Thank you so much for your attention.